We are gathered here today with a shared commitment to promoting health and well-being for the good generation. This event is made possible by the collaborative effort of Department of Obstetrics and Gynecology, Faculty of Medicine, Public Health and Nursing, Gadjah Mada University. And we are honored for the presence of our esteemed speaker, Dr. Jane Conry, MD, PhD, FACOG. Good morning, Dr. Conry. Can you hear me,
I
Doctor?
can hear you well. Yes. Hello. Thank you so much for this kind invitation.
Thank you very much, Dr. Conry, for accepting our invitation. We are also grateful for the support of our host, Professor Dr. Muhammad Hakimi, PhD, obstetric and gynecologist, subspecialized in the social gynecology. Before we discuss today's main topic, let us acknowledge the significance of preconceptional intervention. It creates a foundation for the successful pregnancy and a prosperous future for the next generation. In Indonesia, we have preconceptional intervention program such as the bride and the groom service program. The bride and the groom will do some examination such as physical examination, blood tests, tetanus toxoid vaccination, and premarital counseling. The aim is to detect the early hereditary diseases such as thalassemia and hemophilia, or to detect sexually transmitted diseases such as HIV/AIDS, syphilis, and hepatitis B, which can have an impact on the life of the bride and the groom and their future children. The purpose of our lecture today is to raise awareness about the significance of preconceptional intervention and the positive impact it can have on the maternal and child well-being. Our esteemed speaker, Dr. Conry, will share her insightful talk and her practical advice to empowering individuals and communities to prioritize the preconceptional intervention. As a master of ceremony, I will read several sequences of our agenda. The first is opening remarks from our head of department. The second is a preconceptional intervention lecture that will be delivered by Dr. Conry. The third is question and answer session and discussion that will be led by Professor Hakimi. The fourth or the last is closing. We encourage everyone to actively participate, ask questions, and contribute to the valuable conversation that will be unfold for the next 2 hours. Let's start this event by reciting Bismillahirrahmanirrahim. Moving on to the following agenda is opening remarks by the head of Department of Obstetrics and Gynecology, Faculty of Medicine, Public Health and Nursing, Dr. Ardanu Kusumanto, obstetric and gynecologist, specialized in the oncology gynecology. Please join me in welcoming Dr. Ardanu for the opening remarks. Dr. Ardanu, the time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Adi. Distinguished professor, doctors, our beloved students, trainees, residents, young doctors, also our educational staffs and paramedics. Alhamdulillah, we pray to our Almighty Allah Subhanahu wa Ta'ala, who on this morning He gave us opportunity to gather online or as person in this event, the guest lecture, our guest lecture. I would like to thank to Dr. Jane Conry, PhD, FACOG, who today will give us the lecture about Improving Maternal Neonatal Outcome, a comprehensive guide to preconceptional intervention strategies. And I would also thanks to our beloved teacher, Professor Hakimi, who will act as our moderator this morning. Appreciation also goes to the participants and the committee who have put together this excellent event. Hopefully, we all get the best benefits from this guest lecture. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much for the great remarks, Dr. Ardanu. As we move forward, I'll be handing over this event to our moderator, Professor Hakimi. Professor Hakimi is a retired professor of the Department of Obstetrics and Gynecology, Gadjah Mada University. He is fellow at the Clinical Epidemiology and Biostatics Unit, Gadjah Mada University. Professor Hakimi also a co-principal investigator, Community Health and Nutrition Research Laboratory, Gadjah Mada University. For the academic assignment, Professor Hakimi is chairman of the Committee of Medical and Health Research Ethics, Gadjah Mada University. He is also a chairman of the Academic Standard Committee PhD program, Gadjah Mada University. He is also a member of the Curriculum Committee, Gadjah Mada University, and a member of the Committee on Education, Research and Development, Dr. Sarjito Hospital. Professor Hakimi is a member of the Indonesian Medical Association, Indonesian Society of Obstetrics and Gynecology, and Indonesian Social Obstetrics and Gynecology Association. Professor Hakimi will guide you for the remaining session. Without further ado, Professor Hakimi, the time is yours.
Thank you, Dr. Adi. Okay, thanks, Dr. Adi, for the introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. For Dr. Gondre, it's very early in the morning. Yeah, I think it's 2 a.m. in your place. Okay, it is my pleasure to introduce our guest speaker for today's conference, Dr. Jean Ann Conde, obstetrician and gynecologist, a doctor of philosophy. She finished her Bachelor of Arts degree from the California State University in 1974. And then I think this is a MD PhD program before entering the internship and residency. She moved to take a Doctor of Philosophy at University of Colorado in Boulder, Colorado. Yeah. And then she finished her medical degree in 1986 and completed the residency training in obstetrics and gynecology at University of California, Davis in 1990. She's president, chief executive officer, and founder. That is 2017 up to present. The Environmental Health Leadership Foundation. She was immediate past president, the International Federation of Gynecology and Obstetrics. That was October 21 to October 23. And also past president, the American College of Obstetricians and Gynecologists, 2013 to 2014. Dr. Jean Ann Conde has served as leader in many organizations in her field, including the Partnership for Maternal, Newborn, and Child Health, or PMNCH, from 21 to 23, and then Women's Preventive Services Initiative from 2016 to 2023, the Forum Institute Preconception to Infancy Program, and the Heartland Research Institute from 97 to 2017. She published many articles on women's health across the life course and opportunities for improvement. Yeah. Her current focus is on maternal and child health outcomes, and in particular, the interrelationship among women health care across a woman's lifespan, maternal morbidity and mortality, and the impact of environmental toxicants and climate change on health. As we examine risk to women and children and their health outcomes, it is clear that environmental exposures impact long-term health. She is a leader in climate change and health. She led through empowerment by encouraging leaders and women alike to effect changes that bring about sustainable future where women and children survive and thrive. When we invest in the health of women, we invest in this and future generations. Today, Dr. Jean Ann Conroy will be sharing her insight on conceptional intervention. Ladies and gentlemen, please join me in welcoming Dr. Jean Ann Conroy. Dr. Conroy?
Thank you. Om Swastiatsu. I want to thank very much Dr. Adi Arifiasto for all the logistics, the arrangements for me to be here today. I really very much appreciate the time zone logistics and everything. Dr. Kusumoto for your kind introduction, and then Dr. Mohammed Hakimi for trying to summarize my career so eloquently and in such detail. I appreciate it. I also want to thank Dr. Ravi Chandran from Indonesia, who was my just right hand while I was FIGO president as the trustee, the regional trustee, and now serves so beautifully as our trustee in the secretary position. Dr. Rohana Hatoa from the AOFOG, and certainly the dean of the medical school for being so kind to invite me here today. I'm going to go ahead and see if I can share my screen. Let's see. There. I hope everybody can see that fine. And you have, yeah, good. A topic near and dear to my heart, prevention, preconceptional intervention. And I'm going to give some Indonesia perspective because as Dr. Kusumanto said at the very beginning, you have a preconception program, but I also want to place a perspective on well women healthcare. So I'll lead with one, but really go into a lot of other details here. Let me make sure my timing is correct so that I don't burn you with too much talking. But let me go ahead and begin. And as you said, we're looking at healthy mothers, healthy babies. My mantra for really 30 years has been every woman, every time. And with global health, I say every woman, every time, everywhere. Every touch in our healthcare systems, we need to be talking about well woman healthcare, improving the health and well-being of a woman. So if and when she ever conceives, we've got a healthy infant. And it really takes our focus and a public health focus. So I'm going to give you a little perspective, what we've seen globally and some of my U.S. background of what we've done over the years. And why? Because this means so much to all of us. So really, when we talk about preconception health, we're talking about a woman preparing for pregnancy. But if she has another child, we're talking about interconception health. And we know that for many women, their only contact with the healthcare system before she conceives again is a postpartum visit. So when we're talking about preconception healthcare, one also needs to think about a postpartum visit and how do we redesign it or make it more effective. And my own personal perspective, having started this preconception pathway in the 1990s, is that it's all about well women healthcare. Looking at women across their lifespan and in their reproductive years, focusing on their health. So if and when they decide to become pregnant, we've taken care of them. And the question to ask yourself, are we talking about planning? Or are we talking about accidents? Is it a surprise pregnancy? There was a great summary as you talked about the perspective of healthcare practitioners on preconception care at a primary healthcare facility in Jakarta. And they called it a qualitative study, but it was very, very interesting because I'm so impressed that you do have these preconception visits for a young bride and groom. The interesting comments that came out of it, though, were the study looked at the nature of preconception care delivery towards prospective brides and grooms at a primary health care facility. And they said that the participants found that the prospect is still limited to preparing mostly for the wedding and not so much on reproductive health. So when they were talking with everybody, the couple was focusing on steps still to come and not really planning the family or what that might entail. And in fact, when they asked about the implementation of preconception care, it was fabulous. And I have to say, it is really important that you are doing the blood test, you are doing an STD check. Women are getting iron. This is really important. But when they asked the question, how did you provide preconception care services? They talked about the frequency of care, talked about the care programs, but there wasn't so much detail about what needed to be screened. And it was a response saying they expressed their experience more in place of care and the frequency of care. The type of program, some of the statements from the partnerships said, I was talking about vaginal hygiene. I was talking about hygiene of the individuals, how to space pregnancies, how to use contraception, absolutely important element is family planning. But they also were frustrated because they said they would come up with recommendations and a woman would say, no, my mom told me I could never get vaccinated. I can't do this. And are you going to keep me from getting married if I don't do what you say? So it was a very interesting perspective from that point of view. The participants said that the bride and groom's preparation to produce offspring lacked both physically and psychologically. I would say that's true around the globe. We know that 50% of pregnancies are not planned. They're surprises, 50% of the time. I think the rate in Indonesia is lower than that. It's closer to 38 or 40%, but it's still significant. That means preconception care is missing 40% of the audience. The Lancet had a great series on preconception health. They focused on health and nutrition of men and women before a pregnancy. And they said it's important for lifelong health. And as you said, it's our future, the next generation. Preconception period can be seen in 3 different ways. First, biology. If you have a conception, we've got embryonic development. What is the condition that embryo is developing in? We know from the research that we need to be talking about not just those days and moments, but 3 months to a year before that impacts the health of that embryo. So just making sure the conditions are right at the time of conception is not enough. We know the whole theme that pediatricians have come up with, 1,000 days, misses the whole point because it doesn't allow for preconception care. 1,000 days looks at the baby's first 3 years of life. And we know we've got to talk about prenatal and preconception. The second element that this article talked about is that from the individual perspective, as wanting to conceive, what is that time period? Is it a surprise, or are they really planning and looking at that? And that's where some of our fertility clinics really can step up and make a difference. And then for me, always, it's a population lens. Women of childbearing age, reproductive years. What do we need to do for those women of reproductive standing? I took part in this panel here that's described the Center for Disease Control, ATSDR Preconception Care Work Group. We spent probably, I would say, almost a decade working on preconception care in the United States and came out with some very inclusive recommendations on what we need to do, how we need to go about it, both from an individual, from a healthcare facility, and from a population point of view. In the end, my take-home message is it's well-woman healthcare. If we don't focus on a woman's overall health, we miss about 50% of the population. Out of that CDC, ATSDR movement came before, between, and beyond pregnancy. This is something everybody has access to. It is focused on United States data, but the modules are learning modules that can be for anybody, and they're great. They're learning modules, they're programs. It's online, so you can get a great deal of information about preparing for pregnancy, interconception care, and all the like. And as I said, my own work has been in the Women's Preventive Services Initiative. When women are healthy, communities thrive. Out of all that CDC and ATSDR work came Well Women Healthcare, and this is women's health across the lifespan. I'll get into that much later in the talk to kind of summarize with WPSI. But in 2005, the U.S. National Preconception Health Consumer Work Group set up a social marketing plan because, yes, they said, when physicians are talking about preconception care, that's great. The problem is, if you ask a physician, do they do preconception care well? We all say yes. We think we do a great job because we consider preconception care when a woman comes into our office and we talk with her about it. We don't take any responsibility for all the women who aren't coming. That means that 50% of pregnancies that are surprises. We aren't taking into consideration women that say they're interested, but we don't do anything about it because they didn't come in for a preconception visit. So we miss a number of women. So this marketing said, we need to look at women and make sure that they understand what their needs and their rights are. So they identified two different groups, and it makes sense to me, the intenders and the non-intenders. So the women who say, I want to become pregnant this next year, and then the other women who say that they aren't interested. And we have found that if at every visit in our health systems, we ask one key question, it helps direct our care. That one key question is, are you interested in conceiving this year? One key question. If a woman says yes, we go down the preconception path with all those things. If she says no, it's still that same kind of path, but it's one focused on getting her the right contraception and making sure her health is good. So if she does have a surprise pregnancy, we've still taken care of her. So this was 2005. We're still doing this work to this day. But what came out of it is we've got many different women, many different interests. The pregnancy non-intenders are motivated by improving their health and wellness. And in fact, they kind of resent it if our message is preconception health. We heard very strongly from the women being surveyed that they aren't just reproductive beings, they are interested in their own health. And from the surveys, we said non-intenders are unlikely to resonate. The behaviors around preconception health are unlikely to resonate with women if you focus on preconception care. They say, I don't need it. Then they go ahead and have a surprise pregnancy. So it's the messaging that's really important. You want to focus on a woman's health and well-being. What is it to control her diabetes, regardless if she's going to get pregnant? What is it to control her blood pressure, regardless of whether she's going to get pregnant? So step back from preconception. My message, the only message you need to take home today is strive for a healthy lifestyle for all women, and you will achieve preconception health. One message. But let's get practical. The critical understanding is that preconception health is well woman healthcare. 50% of pregnancies globally are unplanned. And what I found in Indonesia, it looked like it was about 38 to 40% are unplanned. All women should expect and receive routine preventive health care. That's something that the burden we should be putting on women. Expect to be seen by your physician, by your midwife, by your nurse practitioner to help you get healthy. And then one key question, ask them, are you interested in conceiving? And then for me, I'm going to conclude all of my remarks with the environment and why the environment is very important. We found 5 organizing themes. One is around clinical practice, one is around health promotion, public health, public policy, and then we need data, we need research. But out of these 5 organizing themes, we came up with 10 imperatives. These are some of the steps that we need to do and necessary action. First, individual responsibility across the lifespan. You've already achieved that in the sense that women and men, when they're getting married, are going to be coming in for a visit. That's more than many countries around the world. I would say much more than the United States, much more than most countries, that you have that check. That's fabulous. So develop, evaluate, and disseminate reproductive life planning tools for that couple. Get it away from the bride and the groom and say, what is your reproductive life strategy? And then conduct the research on dissemination and create an expectation that reproductive health is a right and it is a basic element of routine health care. But that individual responsibility, I deserve a checkup, is what a woman should say. I need to be seen. But hand in hand with that is making sure that you're doing everything that needs to be done for getting that woman healthy. Consumer awareness, modules, educational curricula. Make sure that we've got consumer awareness, whether that's social marketing, whether it's media partners, whatever it's integrated, you want that message integrated. I call this the empowerment, a right to plan a family. You want those individuals to know it's up to them. The third is preventive visits. Increase health provider awareness that prevention matters. Develop a health curriculum and well woman health care. And again, at the end, I'll go into specifics from WPSI, the Women's Preventive Services Initiative, because we've got a chart that tracks everything. Screening tools, what you need. Do you need incentives in society? Are there underserved populations who just don't come in? How do we incentivize them to come in? And then for our populations, create an expectation that preventive health is a necessary step. It's important for a woman. What is the intervention for identified risks? Well, we need health provider awareness. What are the risks? I think you and I could list a whole number: diabetes, hypertension, come down that list. So increase our awareness of what we need to be screening about, and then create modules on preconception care and well woman care so that we know that what we need to do in each visit. And then make sure our professional guidelines go along with this. Interconception care. As I said, many women complete one pregnancy and they start the next and they don't see anybody in between, or their only visit was that 6-week postpartum visit. What do we do at that 6-week postpartum visit to make sure it's better? Do we talk about contraception? Do we talk about all of the risks that happen during the pregnancy, and how should that matter? We enhance the content of the postpartum visit, use public health programs, and really encourage preconception health. The pre-pregnancy checkup, as I said, you all have really set that as an expectation. It is an expectation that there's a pre-pregnancy visit, but it means that you've got to have reproductive health planning integrated into society, and that we value pre-pregnancy planning. What about health insurance coverage or women with low incomes? Making sure that it's designed and that family planning is an element, increasing access so that the burden isn't on a woman or she gets frustrated. Oh, it takes me 6 months to get in. I'm not going to bother. So how do we make sure we've got access? And that's a health system strengthening issue that is a global problem. What are some of the health programs and strategies? One, integrating preconception health practices. We found in our medical system, I practiced with Kaiser Permanente for almost 35 years, that I needed to talk with my colleagues in internal medicine, in family practice, and speak with them clearly, because they were seeing women and they didn't address preconception health. They said, oh, that's the OBGYN problem. But if a woman didn't come in to see her OBGYN, they really fell through the cracks. So how do we integrate our message with our colleagues? How do we support programs? And how do we provide collaborative groups? Research, research, research. We need to translate research into clinical practice. Much of what I'm going to tell you is not evidence-based. The individual elements are evidence-based. But honestly, to look at a system where they apply all preconception healthcare guidance and can show it drives outcomes, it's just not there. And I'll describe that in one of the Royal College papers that came out. So the research is there for individual behaviors, hypertension, diabetes, folic acid. Individually, we can say yes. But the entire concept of preconception healthcare, even though we voice it strongly, it hasn't been studied as a unit. And And then how do we monitor improvements? Well, that's where we do the research. You look at public health surveillance, target preconception health program, and really aim for where there's poor health outcomes that already exist. So let's look at a couple of the components of preconception care. And here I'm relying on some of the guidance from the American Academy of Pediatrics, the American College of Obstetricians and Gynecologists, and the Women's Preventive Services Initiative. WPSI is funded by the U.S. government. It is part of Obamacare. When President Obama was voted into office and he accomplished the best health coverage we've had, he said he was going to put a priority on women's health. So out of that came WPSI guidelines for women across their lifespan. And now FIGO has adopted much of that and has they put together a Well Women Committee and women's health across the lifespan. So really, when we look at it, there are 4 categories of intervention. How do we screen for risks? Diabetes, hypertension, coagulopathies. What are a woman's risk factors? How do we view her physically? What's her BMI? What's her blood pressure? What has she done with vaccination? And how have we counseled her? So those are important categories. And we can go to almost any list. And at the end, I'll put together a clinical guideline for you that's just a screenshot and a link for you to look at some of the things. But when we talk about some of the components of really good risk screening, reproductive awareness, environmental toxics, and teratogens, we know that women take prescription drugs. How many of those are teratogenic? And does anybody ever tell a woman or ask a woman, are you using a contraceptive when we prescribe a teratogen? Most of the time, no. What is the relationship between nutrition overall and folic acid? Genetics, what are somebody's risk factors? Substance abuse, whether it's alcohol, tobacco, or drugs. What kind of medical problems does a woman have, and what are her medications? What about risks of infectious diseases and vaccinations? In the United States, we've seen syphilis rising precipitously in the last 2 years. Syphilis, we're seeing now neonatal syphilis. And then what about the psychosocial concerns, whether it's mental health, screening, depression, anxiety, intimate partner violence? All of these are things that we need to be screening for. So what can you do? Well, there are preconception care clinical applications. There are different guidelines that you can look at. Our risk factors that we often consider are chronic diseases, infectious diseases, reproductive concerns, genetic diseases, medical treatments, personal behaviors, mental health, environment, contraception, and abortion access. So you've got to look at this entire list and see where a woman fits. Some of the applications that we've seen with the retinoic acids, where we know that those will cause serious birth defects. There is a process where a woman on a monthly basis has to show what type of contraception she is using before she gets another month refill for that medication. That's a very, very tight control. But what about a woman who's on an ACE inhibitor, which can cause major problems? She has hypertension that hasn't been controlled, and she's not on any birth control. Doesn't have an IUD. Isn't that just as important? We've got alcohol misuse. We know that a woman who is using drugs or alcohol early in pregnancy can cause major problems. We also know that a woman who is using drugs and is put into a very comprehensive program lowers her risk to normal if she's put in that at the beginning and receives counseling the whole way through. There are antileptic drugs, diabetes. I'll go into that in more detail. Folic acid. I was impressed with your use of iron. Screening for hepatitis B and C, HIV. Hypothyroidism is a global problem. So making sure that we've got the adequate intake of iodine here is important. And then our known environmental risks. We've got applications in the form of maternal fetal ketonuria. When she's been diagnosed, how do we take care of her? It's pretty important to make sure that she's on the proper diet. Rubella, making sure somebody's been screened for rubella and gets vaccinated. Obesity, oral anticoagulants, STDs, smoking, and then, as I said, the Early Start program for drug use and abuse. This all leads us to what I call well woman healthcare. If we improve the health and well-being of all women, and they elect to conceive, then we provide true preconception care. If they elect to not conceive, we still win. We've got a healthy woman. So regardless of what a woman's reproductive goals are, we want to focus on optimizing her health across her lifespan and asking that one key question: are you interested in conceiving this year? We have to empower women. As I said, we have to have women expect to have the care. All women should have the right to decide if and when they elect to conceive. Not their mom and dad, not their family, not their husband, not society, not a church. It has to be a woman that we've empowered her enough that she feels compelled to decide. It's her right to decide. We've not achieved that. I think you and I all know that we have not achieved that. There are pressures on women to conceive even when they do not want. Reproductive health care is a basic element of all health care, and we have to strongly advocate for that. You and I are scientists. We know what the science says about planning for pregnancy, about healthy women. We know what it says about access to abortion and contraception, that we have a healthier pregnancy if and when a woman elects to conceive, if she's had the ability to plan a family. So it's not the family or religion or politics that determines a woman's decision about conceiving. A woman decides what is right for her and when. And again, that one key question at every visit for women of reproductive age, every year, are you interested in conceiving this year? Is your question you're going to ask. If she said yes, then go over a preconception care checklist. If she says no, provide contraception and well woman health care. Now this is, it's a lot to look at, but it's the Women's Health Agenda from FIGO, Care Across the Lifespan. And here I'm focusing on well woman health care. This last year, just released in October, is a diagram that really looks comprehensively at what we should be doing across a woman's lifespan to make sure we've optimized her health. We need to make sure that we take any knowledge from pregnancy and its impact on long-term health to make sure we consider that. And then Vigo has a division of sexual and reproductive health and well-being. And what that division has said is that we need to let women decide. And if a woman says, I'm having trouble conceiving, we believe we need to do everything we can. But if a woman says, I don't want to conceive, we need to do everything we can. And if a woman says, I need to or want to abort a fetus, we do that. So whether it's contraception access, safe abortion, or reproductive medicine, the power is to the woman to decide what her needs are. So let's look at some of the preconception care research and the impact of systematic approaches. We know in healthcare systems that are focused on hypertension control, if you do it systematically, so that we have a goal, we've got a medication, and we've got a follow-up, and we follow those patients systematically. It often takes an electronic record. Blood pressure decreases, cardiovascular disease decreases, heart attacks decrease. So systematically, we know from internal medicine that we can do that. We just haven't done that in OBGYN. In Mexico, they did a 4-year campaign in Nuevo Leon, Mexico, trying to reduce the incidence of neural tube defects. Every woman of reproductive age got a tablet of folic acid every single week. It became a community empowerment, free distribution, public policy campaign, community support. They saw 50% reduction in neural tube defects. Now, we went to our health system and said, hey, we know that women who are diabetic are going to have a higher incidence of cardiovascular problems if they conceive. They're going to have a higher incidence of neural tube defects. Could we just give every woman a vitamin every time a woman's in there, if she's reproductive age and she's filling her prescription for metformin or insulin, we give her vitamins and say, take these regularly? We could not get our healthcare system to do that, yet it makes sense. So how do you do it systematically? We defeat ourselves. We do have preconception guidance. That guidance, as I said, on one, we've got the before, between, and beyond campaign that looks at before, truly planning for pregnancy, between the interconception care, and beyond. How can we use pregnancy to predict a woman's life risks for other medical, usually cardiovascular disease? And our second is consulting the Women's Preventive Services Initiative, the guideline and the chart, because of the care across the lifespan. The easy link for you, again, it's US focused, but it doesn't matter because the message is the same. Before, between, and beyond pregnancy. If you just do a Google search with that, you can go into modules, you can go into programs, you can take and use anything that you would want because it develops entire educational curricula if you want to institute that in your office or in a health system. So it's all right there. The preconception coin program is linked to a maternal morbidity and mortality program to reduce the complications a woman might see during pregnancy. So it's these linkages that are really and truly important. And then WPSI, the Women's Preventive Services Initiative, I'm glad to say came out of my year as president of ACOG. We had a well woman committee for 1 year. And out of that, we applied to the US government and have received now $15 million in grants to focus on women's health across the United States, optimizing preventive healthcare. What we found, and the reason we did this, was if a woman went to her internal medicine doctor, she got one type of advice. She went to a family physician, she got a different bit of advice. She went to a nurse practitioner, it was a third bit of advice. She went to a midwife, it was different. An OBGYN, we all were giving different messages, somewhat aligned. We said, forget this, you're putting the burden on the woman. Let's take the burden and put it on ourselves. So all of the societies that take care of women across their lifespan meet on a regular basis and come up with guidance. And if we make a recommendation, the US government obligates almost all their insurance to cover this at no cost. So it's been a powerful incentive. And I put this here as the organization of the Well Woman chart. Get my glasses on, it's tiny print, it's bigger on your computer, but you can see it's starts, we work with the American Academy of Pediatrics, so ages 13 to 17, 18 to 21, all the way on up to 75. And these are the preventive services. And, you know, we have the U.S. Preventive Services Task Force, but they don't address all of these issues. We wanted things that are really important for women. So let's skip down here to blood pressure screening. We believe all women should be screened for blood pressure. If we look at cardiovascular disease, it's going to start screening around age 50. Folic acid supplementation, maybe for our early teens, but then for sure reproductive years. Tobacco screening, all ages. So it's one of these that shows across the lifespan. So whatever age we're looking at, and then we can look at general health and see what the recommendations are. We've got the same thing for infectious diseases, what age ranges we should be screening and what it should be done. Cancer, the same thing. And this is all of the societies that take care of women. We've got one for pregnancy and we've got another for postpartum. All of these are in a nice, easy app. What I like most about it is for every single one of these recommendations, we then pull it out. So this is anxiety screening. It was interesting. This one came out during COVID. The rationale for addressing this is anxiety disorders can be treated. They are very common mental health disorder. 40% of women experience anxiety at some time in their life. So if you don't screen, you're missing 40% of the population. We then come up with a recommendation. Screen for anxiety in adolescent and adult women age 13 and older. And then we give tips on how to screen and provide the references. So it's very thorough, and we do that on every single one. So you can get a lot more detail than we just have in the table. And then for those who are interested, you can do a screenshot of the interactive chart. And on the right, you're seeing how it goes through the different elements. You can download this to your iPhone, and it'll give you all of the information you need. Again, I know it's US based, but the guidance are pretty much what we would do anyway about diabetes or hypertension. They're all there. So you can see it's working its way through, teaching all the steps on how to load it and create a favorite, add it to your home, and you're set. And all you have to do is put in WPSI on a Google search and everything will come up for you. So let's look at a couple major topics around preconception. What are some of the major risks that should be addressed before pregnancy? And this is not an exhaustive list, excuse me, but it's some of the ones that I think are really important to consider. Obesity. This was a great review of the literature addressing obesity in preconception, pregnancy, and postpartum, a review of the literature. Obesity decreases fertility during the preconception period. It increases the risk of adverse pregnancy outcomes, increases the risk of gestational diabetes, increases the risk of preeclampsia, increases the risk of cesarean section, and long-term, remember I showed you that one part on our FIGO structure of all of our committees, pregnancy and long-term health. Obesity increases the long-term risk of cardiovascular disease. The global prevalence of obesity has increased in just 40 years from 6 to 14% of all women, but around 40% of women over 18 are overweight with a BMI and 15% have obesity. Overweight and obesity are associated with infertility. And then we've got the epigenetic programming that occurs at conception. So a woman who is obese predisposes her children to chronic medical conditions, type 2 diabetes, and heart disease. So her children, just from her exposure while she's conceiving. This is back to the Show Your Love campaign for before, beyond, and between pregnancy. You can go to any type of topic and find out, but they did a whole social media campaign on how to show your love for yourself. So again, getting away from just calling it preconception health, they called it Show Your Love. How do you focus on your health? A woman, how does she decide her health is worth it? And they thought Show Your Love was a positive message. Let's look at diabetes. Diabetes prevalence and risk factors of early onset adult diabetes results from an Indonesian family life survey. So this is a 2021 study looking at it, particularly in Indonesia. And I thought this was interesting. It's kind of hard to look at, but we've got one part of the graph is women reporting whether they have diabetes, and men down here, and then women being tested for diabetes. And you can see there's anywhere from a 2 to 4-fold difference between I have it or I test positive. So lack of recognition that an individual even has diabetes because they've never been tested, they've never been asked to be tested, they've never talked about it. So it's much more prevalent than we want to know. So whether it's a woman deciding she needs to be tested or you as a clinician saying, I need to test you, that screening is important. Diabetes is increasing rapidly in Southeast Asia. There were almost 6,700 participants tested with their hemoglobin A1C, and 8.4% had levels that we know can increase the risk of neural tube defects and cardiac defects. That's a hefty number. Let's look at the complications from diabetes. You and I see this all the time. We know that infants born to moms with type 1 or type 2 are at risk for congenital anomalies, perinatal mortality, and morbidity, short and long term. Lifelong, we know for sure. Hyperinsulinemia is associated with neonatal morbidity. And we've all seen that with the babies that get admitted to actually just to a regular postpartum wing and then end up in the NICU because their blood sugar bottoms out. We see stillbirth, neonatal mortality, and congenital anomalies. And we look at the list of congenital anomalies. I think all of us think cardiovascular, cardiac defects, certainly transportation of the great arteries, ventricular septal defects, central nervous like neural tube defects, GI, duodenal atresia, musculoskeletal, arthrogryposis, urinary tract defects. Caudal regression is one that we've always heard about, cleft lips, palate anomalies. So major defects simply because we did not screen or get a woman's blood sugar under control. I saw women when I was on call, and this isn't a fully integrated healthcare system. The woman had gone in the year before for a miscarriage in the emergency room. The doctor took one look at her and thought, you look like a diabetic. He did her blood sugar. Her hemoglobin A1C was 14. he referred her immediately over to internal medicine. And over the next 6 months, they put her on medications, on statins, on blood pressure medications, on insulin, everything. Got her hemoglobin A1C down to, I think it was 9.5. No one ever talked with her about pregnancy. No one ever talked with her about being on a birth control pill. And here she'd come in miscarrying. Not one person. She had 15 different types of visits. Guess what? She missed her period and she was pregnant. So she came in to see us. Thankfully, we did an anatomic survey and everything was fine. But she was the perfect example of how we need to collaborate and integrate, because this was a woman with known risk factors, had high levels, and just wasn't treated in a collaborative fashion. You and I have to go to our colleagues in internal medicine and family practice and talk with them about these patients. Hypertension. Gender differences in prevalence and risk factors for hypertension among adult populations. This is a look at Indonesia from 2021. Although hypertension is among the main public health concerns in Indonesia, because of a scarcity of data, there are very few studies on them. But more women were diagnosed with hypertension than men, 50% versus 33.7%, which I find fascinating. That's different than other population. But they weren't under good control. Only about almost 16% of women had their blood pressure controlled to less than 140/90. So if this is a woman who we have not talked with about contraception, who we didn't ask that one key question, and she's got her blood pressure elevated, she's not in a good control level at all. What does that mean? It means we've set the pregnancy up for major problems. Higher preconception blood pressure among healthy women can increase the risk of hypertensive disorders of pregnancy. An increase in blood pressure in early pregnancy is probably a risk marker for pathophysiologic processes. It's associated with preeclampsia. And a new onset of hypertension is common with gestational hypertension, anywhere from 2 to 4% in pregnancies. So we've got these risk factors and we didn't do anything about it. This is a woman where she needs to be on aspirin early in pregnancy because of the concerns with preeclampsia. These are the nice guidelines that have come out, preconception advice for women with chronic hypertension. Number one, pre-pregnancy advice is get care. See a specialist so that you're getting care. But that's only for the woman who comes in, right? If we haven't asked her, we haven't planned properly, she's going to come in on a medication. She might come in on an ACE inhibitor or a blocker. There's an increased risk of congenital abnormalities if those are taken during pregnancy. So here we've got a woman who has a known risk factor, should have seen a physician, but didn't come in planning for her pregnancy. We should stop antihypertensive treatment and get them on alternative medications. And they're there. The thiazide diuretics, there may be increased risk of congenital abnormalities. Again, alternative medications are available, but only if we started at preconception. You and I know that, but if she's seeing her internist or a family practice doc, they missed it. We can advise them. And then we know what we'd like her control to be better. And if they're using medications, we want it 135 or 80/85, nifedipine, labetalol, methyl-dopa, Aldimet are all great medications. And then offer pregnant women with chronic hypertension aspirin daily after 12 weeks. And then the area that's dear to my heart is environmental toxicants. The air we breathe, the water we drink, the food we consume, and the products we use. All of those have potential toxic chemicals in them that impact a woman's ability to conceive. They impact the health of the fetus, and they impact children's health associated with all of those. WHO has recognized this. And this summary article looked at occupational environmental exposures and said we need a sustainable world. We've got guidance on how preconception exposures affect developing children. We know clear association between pesticides and autism. This is a European direction, huge studies out of Europe. They've probably got the best research going on in the world. And then this was out of FIGO, making sure that we need to talk about environmental justice. We need to be champions. FIGO has come up with a strong statement. The American College of Obstetricians and Gynecologists wrote one of the most thorough summaries on exposure to toxic environmental agents. And then for you and me, they published a committee opinion, how to reduce exposures. And I don't have the graphics here, but on that one, you can look at every classification and see what you need, what the risks are. We know mercury in fish, but phthalates and PFOAs in our phthalates or PFOAs in some of our personal care products, those are all associated with fetal abnormalities. This is a great summary article, came out in 2019. And in it, they talked about infertility, spontaneous abortion, and genetic damage to the fetus that can result in birth defects. We've got a lack of accurate assessment because a woman is probably taking 4 or 5 or being exposed to 4 or 5 different chemicals. So one chemical will be studied, but how often are they studied in conjunction with one another? It doesn't happen. So there's a multiplicity of exposures that impact women's health. My personal concern, I've got the pulpit here, prenatal vitamins, pesticides, personal care products, water, cooking and food preparation, climate change, and air pollution. But let me talk about prenatal vitamins. Environmental toxicants is a consensus that preconception exposure can adversely affect fertility, pregnancy, and fetal development. There are 80,000 chemicals registered in the United States. We know that chemicals that are banned in the United States are being shipped outside of the United States and used in low-income countries. And this is just an example of one of the graphics that you can say, let me look at an endocrine disrupting chemical. BPA is associated with obesity and poor oocyte quality. What are the sources for it? So you can look at something like that and determine risk factors. But let's look at the vitamin study. 39 of 39 tested prenatal vitamins in the United States and Canada. 39 of 39. Every single one of them had a toxic chemical in them. Lead, mercury, arsenic, cadmium, PFOAs, phthalates, BPA, things that we should never prescribe because nobody tests. They tell us what they are, but nobody tests to see what's actually in them. So we are now working on a testing, and it's going to have a little stamp of approval called P2I, preconception to infancy, that says it's been tested and has none of the chemicals that we're worried about. FIGO came up with a statement. FIGO recommendations, patients should only consume and clinicians should only prescribe vitamins and supplements that have independently assessed to make certain they do not contain contaminants. Toxic chemicals and contaminant determination. We come up with a group of scientists from around the world and come up with, if you call it the no-fly zone, the chemicals that we should not be exposed to. FIGO's position is that potentially toxic environmental chemicals should not be found in products. Clinicians should educate consumers about the risks of unverified products. And our statement says all prenatal vitamins should be certified, and that should be our standard of care. If it's not certified, there's no one to say it's safe. And I guarantee some of these vitamins didn't even have folic acid in them. So the conclusion, the magnitude of chemical exposures and their effects on perinatal, parental, fetal, and postnatal health make it imperative that we know about these risks, and a preconception visit should be able to look at that. When we improve the health and well-being of women, we're not only investing in this generation, but in future generations. As our wonderful physician introducing this program said, it's now and our future. Reproductive health is a right. Women should be empowered to choose if and when they become pregnant. Timing's everything. And we succeed only when well-woman healthcare is expected and achieved. This is the Environmental Health Leadership Foundation for Global Environmental Health for every woman, every time. Everywhere. And this is why. Thank you. I'm going to stop sharing. Thank you very much for inviting me here.
Thank you very much, Dr. Jean and Kandre, for your very comprehensive, interesting and stimulating presentations. Before moving to the discussion or questions, as questions answer session. Let me have a concluding remark to your presentation. There is sufficient scientific evidence that quality pre-conceptional care and antenatal care can improve newborn survival and maternal health. Yeah. The presentation was conducted to understand the concept of pre-conceptional care and its implementation status. Yeah. The review documents the specific interventions that have been proven to effectively improve pregnancy outcome when provided as pre-conception care. Healthcare providers, particularly obstetricians and gynecologists and general physicians, should prioritize pre-conception care as an essential component of healthcare for women. However, the lack of continuum of care and program linkages are some of the key barriers in ensuring preconception and antenatal care. Culturally and linguistically, appropriate care should be provided to ensure that all women can access and understand the information and services needed to optimize their reproductive health and improve pregnancy outcomes. And then prioritizing preconception and prenatal care, healthcare providers can improve maternal and fetal outcome, reduce healthcare costs, and promote lifelong health for women and their families. The primary healthcare reforms being done in many countries can be and should be used to strengthen preconceptional and antenatal care services and quality. Okay, then we now can move to a discussion and question and answer session. Those who have questions or comments can raise their hands on write down their questions on the chat box.
Get my glasses on to read questions.
Okay.
Thank you, Professor. Thank you, Dr. J.N. Conry. We are very honored to have you here. I'm Sarah from OBGYN department in Yogyakarta. I think your presentation was really nice and really comprehensive to show us what is the ideal type of preconception care for the women. However, in our country, as you also mentioned previously in your first talk, that it's very rare that a woman comes to our clinic long way before they are planning to conceive. So in your opinion, what is the most optimum or the most feasible way for us in the clinics or in the healthcare facility to optimize a very short period before their pregnancy? Because in your presentation, it seems like we need more time before the conception. Thank you very much.
No, I think you hit it exactly where we should be. And we haven't achieved that in the United States either. I always used to joke and say, I need some big movie star who talks about preconception health, because I think our patients will listen more to musicians or actors than they do to their physicians. I would say an expectation for all women of reproductive age to take a daily vitamin. It does, well, once we've certified them, but right now it doesn't matter which brand. Eventually it will matter which brand, because only ones that have been certified should be taken. But a daily vitamin, because of its impact on neural tube defects, on cardiac defects, even on autism, daily vitamin. So messaging for people out there is key. I jokingly said if we could have women, and it doesn't have to be prenatal vitamins, because all vitamins, at least I think in the United States, and I think globally, all vitamins have the right amount of folic acid. So if every vitamin has it, it doesn't matter if it's prenatal, it can be one a day, you name it, a brand. I think pretty much the requirement is they all have the right amount of folic acid. If we could tell women it makes their hair look prettier, we'd have a sales pitch. We don't. So I would say number one is a vitamin. And then it is an expectation, again, social media, that women believe they deserve to be seen and have a visit, not just to plan the pregnancy, but for their own health. I think for us, it's that message that women's lives are important. And we have to tell women how important they are. And we have to be able to say to them, we're concerned about your health. Please take time. It's only 30 minutes a year. Come take time to see us so we can talk with you about your health. They're hard messages. And we failed because 50% of pregnancies around the globe are not planned. That means 50% of the time we aren't carrying the right message to our patients. Hope that's not too doom and gloom.
Okay. Do we have another questions or comments?
Yeah. Thank you very much. I'm Dr. Eugene from OBGYN department. Yeah, I want to ask from your presentation, it's very nice, but one of things that I want to become our consideration, how if we start earlier, if we have the condition at the adolescent condition, where the young girl, we can have early screening, like in the high school and all. So if any problem, if we found it, we can start to have a follow-up earlier rather
Absolutely.
than conception. What do you think?
Absolutely. That's why in that WPSI that I talked about, we are partnering with the American Academy of Pediatrics so that we make sure that we get those 13 to 21-year-olds that sometimes cross over. They might be seeing a pediatrician, they might be seeing an OBGYN, they might see just a family doc. If you look at the WPSI guidance, it goes from 13 to over 75. And I think focusing on them, we don't do enough for our pediatric population. We don't do enough for young girls. We don't set what I believe an expectation of, I don't want to call it family planning. That's assuming a girl wants to conceive. It's more the expectation of empowering a young girl that she is responsible and knows what her body needs, what she needs in life. And so how do we empower our youth is the most important message we can get to that pediatric population. No, you're exactly right. We have to start younger. And so that's, again, that collaborative message.
Thank you very much. Because we have the very big opportunity if we start earlier, so we can any problem like we see, like the preeclampsia condition. It's will be happen if the pregnant happen in the very young age, you see, and also like the like we in our country have the stunting, the stunting program. The problem of the stunting, it is also we can make better treatment if we already start earlier. Thank you very much.
Okay. Thank you. Great suggestions. Yeah. No, that's really where we've got to be. But getting them to expect that their health is important, that they are empowered. It's a cultural change, a belief change in our kids.
So become a good collaboration between the OBGYN and the pediatric. I think can become one good project to make early detection since the adolescent condition. Thank you.
Yeah. Great observation.
Okay, next questions or comments?
Prof. Hakimi, Dr. Jenny. Hi, my name is Sinta. I'm from OBGYN department. I have a question about postpartum care. In Indonesia, we have already had postpartum care, and you mentioned that postpartum care actually is interconception care. So could you explain to us what is the ideal postpartum care in Indonesia? Right now, we only check for whether there is postpartum depression or there is problem in lactation. But but could you explain to us more about this interconception care? Thank you.
Yeah, what a great question that is. In California, oh gosh, I'm trying to remember what year, probably in 2008, I think, we partnered with the California Department of Public Health on an interconception care project, and March of Dimes funded it. And we called it ABCs because it was, let's see, breastfeeding contraception, folic acid, breastfeeding contraception, to make sure we at least hit those three things. And then we came up with an entire list of things. But it was redesigning the postpartum visit, because the postpartum visit almost always was just a social, hi, bye, baby's really cute. Let me see if you want contraception, and you're out the door. And it doesn't do what it needs to do, because we know that about 30 to 40% of women have some risk that occurred during pregnancy that is going to impact their long-term health. Cardiovascular disease. If a woman was obese, if she had diabetes, if she had hypertension, she's got high parity, if she's got more than 5 children, or if she had a preterm delivery or a low birth weight infant, all of those are long-term risk factors for cardiovascular disease. Well, if she never talks with us about it again, or we don't address it at that postpartum visit, we are the best ones to provide long-term health screening at that postpartum visit and tell women what we expect. So if a woman had one of those 6 diagnoses, boom, I would be telling them, saying, you have a 2 to 4-fold risk of heart disease, dying of a heart attack about 20 years down the line. We don't do that. We need that in their medical record, and we need to have that conversation with them. So that's one of the things in the postpartum redesign. The second is making sure that they really are up to date on all of their vaccinations. They may have missed out before, so making sure we've got their vaccinations and contraception. So it is going beyond a social visit and really realizing it. We looked, and in parts of the United States, the postpartum visit rate was kind of in the 50% range. We looked at what some of the barriers were. I know we did it in our own medical group, and our medical group patients had, covered health care. They didn't have to pay for their visits, and we were still only hitting, I think, 80%. And then we realized it was a simple point of booking their postpartum visit while they were still pregnant, increased their attendance rate, because we were telling them right then, this is an important visit. So it was partially us that we were telling them, we really want to see you after the baby comes so we can talk about all of this again. So there's messaging, there's content, and it's really realizing it's long-term health.
Okay, thank you very much.
Thank you.
Okay. Dr. Jean and Pandre, we have OBGYN specialists and also students and interns attending this conference. Maybe we have any questions from them?
So those students are the ideal ones for collaboration, because they may not be going into OBGYN, they may go into some other specialty. So remembering this information, regardless of what specialty, you're the ideal ones to take that message over to pediatrics or to family practice.
Yeah, okay. While waiting for another comments, I have questions. Dr. Conley, in your experience, what is the most important ethical issues that might arise on the pre-conception care? Ethical issues.
Ethical issues. That's a great question. I think drug, alcohol, and smoking, making sure that somebody understands what their risks are, how it's going to impact the pregnancy and the fetus. There's a whole ethical discussion on even screening women and whether women should be screened. And some people say, oh, they shouldn't be screened because that's their private issue. What we found in our medical group is we screened everybody. If you selectively screen, then you're using your own personal judgment. You're deciding who's at risk.
Okay.
And no study has shown that we're good at identifying risks of alcohol, smoking, drug use. If you screen everybody, you identify those that are at risk. But then part of making sure that we follow this ethically is for everybody who's screened positive, you must get them the support to address those underlying issues. And that support, when you couple screening with support, you find that the complication rate drops dramatically. It goes down almost to normal for somebody who's screened and stays in a treatment program. Their pregnancy complication rate is low.
Okay. Yeah. Do you have questions or comments?
Professor Hakimi, in the chat, we have Dr. Fitriana Ekawati. She's raised the hand.
Okay, let me look. Sorry.
So I've lowered my hand. Good morning. Thank you very much for the wonderful presentation here, Professor Jane. If I may introduce myself, I'm not an obstetrician. I'm a family doctor by training. And I just want to make a comment because I hear that primary care was mentioned a couple of times in your presentations and also in your talks. And at the moment, I would like to also say thanks to my colleagues from the obstetricians for helping us in primary care. We're currently developing kind of like a preconception care design in primary care that we kind of like invite women to attend puskesmas or to have consultations with the doctor so that we can like triage them into like green, if for example, if they don't have any complications, or if like, for example, yellow, if they have complications that we can still deal with by modifying their health behavior. And also with red, if we think that we need to refer them to obstetricians before they're planning for the pregnancy. And we also like this year, we plan to pilot the implementations of the design in primary care by asking one questions to the women whether they planning to have their pregnancy in the next 1 year or not.
Yep.
If they
One key question.
want to plan for the pregnancy, then we kind of like invite them to attend the consultations. However, if not, then we can just wait. I think I'm really grateful for this, for having this kind of like opportunities to share my comments. And also we would like to extend our invitation to collaborate with the Department of the Obstetrics. Thank you very much.
Thank you. And one of our biggest observations, and this again gets down to the communication, we saw that women who had a complication during pregnancy, like I said, diabetes, hypertension, grand multiparity, stillbirth, that group of 6 diagnoses, we were putting those notes in the medical record, but everything we said in the note said gestational hypertension, gestational diabetes, gestational this. And when they got over to our colleagues in family practice, they would see, oh, it's gestational. They're not pregnant any longer. They resolved the problem. So what it took was 2 steps. Number 1, education. The gestational, the way we were using it, it was correct. It was in pregnancy. So instead, we changed our wording. We created the note in the electronic record said at risk for cardiovascular disease. Then our internists and family practice docs never got rid of the diagnosis. So our line said at risk for cardiovascular disease. And then in our notations, we would put gestational hypertension, gestational diabetes, grand multiparity, and do the explanation down there. So it was that little communication where we realized you all were seeing it one way, we were meaning it a different way, and just one line difference keeps it in the medical record. So for the woman, the rest of the woman's life, it's going to be there. Whereas anything that just said gestational, it gets resolved in the electronic records or in people's charts. It looks like, oh, they're not pregnant any longer. Yeah. So it's that collaboration and communication. Thank you.
Thank you very much.
Okay. Do we still have questions or comments?
Excuse me, Professor Hakmi. We have Dr. Aryawan Sujono in the Zoom. He wants to ask a question.
Well, please, Professor Aryawan.
I'm not going to ask, but thank you very much for your lecture. I just propose to the society to that the topic about preconceptional health be programmed in our next scientific meeting in Nusa Tenggara Timur, in Kupang, because I think it is important for the gynecologists to know exactly the problems in Indonesia. Thank you very much.
Thank you. And congratulations for considering that.
Dr. Jean Conry, that the next Indonesian annual scientific meeting of the Indonesian Society of Obstetrics and Gynecology will be held in Kupang. So Professor Aryawan stressed that the topics should be put as a theme for the meeting. Okay, any other questions? If not, then I still have one more question. Just recently, the WHO announced a call for proposals. That's the objective of the project is to develop a manual for antepartum care, interpartum care, and postpartum care. Yeah. Do you think that we need to suggest to WHO to add preconceptional care?
Well, like I said, my personal belief is that we start looking at well woman healthcare and making sure that women know they should expect to come in, whether it's for cervical cancer screening, they just need a health checkup every 1 to 2 years. And at that, it's our duty as clinicians, regardless of our specialty, whether we're a midwife, a nurse practitioner, an OB/GYN, a family practice doc, internal medicine, it's then our duty to come up with the checklist. So the WPSI has a checklist for everybody. You can change it based on your country, on Indonesia's risks and things like that. So you might change some of the screening ages a little bit, but it doesn't take a lot of work. And FIGO's has come up with some recommendations there. So to me, you do, as we heard from our colleague, you do well women healthcare and ask the one key question. Are you going to conceive? Do you want to conceive this year? She says yes. Then you make sure you've got her vaccination done right then. You don't let her out of the clinic without being fully vaccinated. Don't let her out of the clinic without having her STD checked, her hepatitis B and C, all of those things, having a hemoglobin, like you said, for that preconception visit you guys already do, knowing what her hemoglobin is. It's all of those things I think are most important.
And do you think preconception self-care is something that need to be thought of too?
Yeah, I look at self-care as an element of women's empowerment. A woman knows what her needs are. She knows what she needs to take care of. She needs to be empowered to do that. So to me, self-care is an important element. Yeah, good point.
Okay.
Yeah.
Okay, thank you.
Excuse me.
Hello?
Excuse me, Prof.
Oh yes, there's somebody raised his hand, Dr. Mati Pariata. Okay, please, you can directly ask your question.
Thank you very much, Prof. Prof. Hakimi. My name is Dr. Pari from Bali. I am obstetrician in Faculty of Medicine, Warmadewa University. I have some question. The first, here in Bali, we have a program about the preconception, but still the barrier of culture make the program unsuccessful. The barrier, the one of the barrier is that in Balinese teenage that there is no, if there is no pregnant yet, there is no marriage like that. And then I want to ask, how about we can make a strategy to improve the barrier culture. And then the second, I think for me that one of the most important thing to the preconception counseling is that we have to do the reproductive health education for teenagers and also improve nutrition status for teenagers. And then we have a policy also, if I'm not wrong, LCMIL from BKKBN, electronic siap nikah and dan hamil, or in English is electronic for readiness to marriage and pregnant. I think that is a good policy from the government, but in the implementation, I think we still improve because the implementation is not so good. I think that is all, Prof. Thank you very much. Yeah.
Thank you. It does get back to that early article I referenced, the intenders and the non-intenders. If you got somebody who's not interested and you keep using the term preconception, they turn us off because even though they may get pregnant this year, they're not interested. So they just don't pay attention to any of our messages. And how do we overcome that? We have to develop a culture where women are empowered and believe that their health and their well-being is worthwhile. They can leave the kids at home. They can leave their husband at home. They don't have to be married. They just need to come in so that we can focus on their health and well-being. So I think it's our messaging that we need to change. And we do that messaging in a social media campaign with the women about why their health is important. So I think, and that's the summary of that, where they were interviewing in Jakarta, the healthcare providers saying, you know, the one that's required or at least offered for everybody who's going to get married, they already were the intended, but they're so focused on other things, the messaging wasn't as clear as it needed to be. So I think your observations are right on. So it's how do we change things? How do we get social media people, the TikTokers or all those people, to talk with women about taking care of their health? And I don't mean it's all of health. It's a healthy diet. It's walking or exercise. It's believing that yoga is a relaxing element for their well-being, their mental health. It's hard messaging.
Okay, Dr. Kandri, in the chat box, there's questions. Should I read it for you? From Dr. Ilham Sejahtera Lupis. Good morning, Professor Jean. I want to ask you about the relationship between the demographic transition and the comprehensive guide to preconceptions. As we know, there have been many changes in lifestyle and health status, from infectious diseases to degenerative diseases.
Well, I think those are all elements of being able to screen somebody for known risk factors and for her health, and then knowing which ones may impact a pregnancy and then which ones will impact somebody's long-term health. But you're right, many changes in lifestyle and health status certainly come about from degenerative diseases. So making sure we focus on a healthy, Mediterranean diet, if you will, or, healthy diet is really the crux of what we need to be doing. I'm not sure when you say the demographic transition in the comprehensive guide, to me, the demographic transition is the expectation that women should have an expectation. It's their right to see somebody who's knowledgeable and is going to talk about their overall health needs. And that's why we did the WPSI and why we created an easy chart. You can hang the chart up in your exam room. You can print the chart out. You can put it on your cell phone or an iPad. It's right there. And you can have a woman who, while she's waiting to be seen, have her printed chart and look at it. And right then she knows what she needs for her own health care. So I think having a chart is ideal for both the woman knowing what she needs and us being reminded. We have our medical assistant put it out so that the woman knows ahead of time what some of the expectations are.
Okay. Do we still have questions or comments? If not, then on behalf of the audience, I would like to thank Dr. Conry for once again very stimulating presentations.
Thank you so much.
And then I give back the time to the organizing committee, Dr. Ari Arifianto, the host.
Thank you very much, Dr. Conry and Professor Hakimi for the incredible discussion today.